I have breast cancer.
I have breast cancer.
I have breast cancer.
And I needed someone to talk to.
I needed information.
I needed to know I could do this. I found Living Beyond Breast Cancer, an organization that understands what you need and need to know. They helped me, and they can help you too.
I have breast cancer.
And I have support.
I have information.
And I have hope. I have Living Beyond Breast Cancer. Find 5 ways we can help you at 5ways.lbbc.org.
Hi, everyone. I want to welcome you to Living Beyond Breast Cancer's program called Genomic Testing and New Directions for Treatment. I'm Jean Sachs. I'm the CEO of Living Beyond Breast Cancer, and I want to welcome both everyone listening and watching via live stream from around the country, as well as our in-person audience this evening. For those of you that are new to Living Beyond Breast Cancer, our mission is to connect people impacted by breast cancer with trusted information and a community of support. And we do that in a lot of different ways, and this evening is one way that we do it, which is bring a topic and help you understand something very complicated, give you a chance to ask questions and learn from an expert that you couldn't easily talk to. But we do physical conferences. We have a website with a lot of information, lbbc.org. We have publications. We have a helpline. So encourage all of you to stay in touch with us as you sort of navigate through breast cancer and let people know that we're here. So tonight, I want to first thank our sponsors for the program, Genentech, Genomic Health, and Merck. It is really important that you know we couldn't do any of our programs without our corporate partners, so we really do appreciate their support. We are taking on a complicated topic tonight, and one that we know there's not a lot of information about. And I think some people are saying, you know, what is genomic testing? What is genomics? What is genetics? So we want to spend some time tonight really helping people understand what it is. Is it ready for prime time? Is it something you should be talking to your doctor about? And hopefully, by the end of this hour, we're all going to be a lot more educated. I'm certainly hoping I will be a lot more educated myself. So we are very fortunate. We flew in just today from Boston, Dr. Wagle, who has been a good supporter of Living Beyond Breast Cancer for a very long time. He has very great credentials. He's with Harvard Medical School, Dana-Farber Cancer Institute, and the Broad Institute of MIT. And he is excited to sort of spend maybe the next 15 minutes just talking to you about genomic testing, giving us a quick 101, and then we're going to hear from some women that have actually been tested, and then we're going to take questions. But you can start texting in your questions at any point, and Janine and I will be going through them. So I'm pleased to introduce you to Nick.
Well, thank you. And thanks to LBBC for inviting me tonight to talk about this important but very complicated topic. Now, in 10 minutes, I don't think we're going to be able to talk about all the details and nuances of genomic testing. But what I thought I'd do is start with some definitions and a bit of a primer and highlight some of the key issues in genomic testing in breast cancer, and think about this as really the beginning of a dialogue that I imagine will continue for the next hour, but then continue even beyond the next hour in ongoing conversations. So to start, I want to make sure we all understand what we're talking about. We talk about genomic testing or genetic testing, but that encompasses a lot of different things. And the first distinction to make is whether we're talking about germline testing or tumor testing. Now, every person is born with their genome, their genes that they inherit from their parents that affects everything about their bodies. And we can do testing, any one of us can do testing for our germline. And that's the kind of testing that people get when they might have a risk for developing breast cancer at an early age. So that type of testing uses a blood sample. You look at the genes that you inherited when you were born, and you might be able to detect things like BRCA1 or BRCA2. That's not the kind of testing we're going to talk about today. We're going to talk about tumor testing. Now, tumor testing is when we conduct molecular or genetic tests on a piece of tumor tissue. And there are a whole variety of tests. And the point of these tests is to help us understand what's going on in the tumor, to improve our ability to diagnose, to think about prognosis, or to think about therapeutic options. And the kinds of tests that we can do on tumors include simply looking at the tumor under a microscope, looking at the histology, doing testing for receptors like the estrogen receptor, progesterone receptor, and HER2, doing tests that help us think about, in early stage breast cancer, the chances of developing a recurrence, or the likelihood of needing chemotherapy after an initial surgery, tests like Oncotype DX or MammaPrint. And the fourth type of tumor testing is what we call next generation sequencing, or sequencing panels, or panel testing. And that's where we look for alterations in the tumor that might be vulnerabilities that might help us pick therapies that target that tumor. And it's this fourth test, sequencing or panel testing, that we're going to focus on today. Now, all of these tests together comprise what we call cancer precision medicine. And cancer precision medicine is really the use of clinical, pathological, molecular, and genomic testing to choose the appropriate therapy for each patient at the appropriate time. And when we think about precision medicine in breast cancer, as I said, we think about three different things. We think about testing for receptors, ER, PR, and HER2, and knowing those receptors, which have been around for a long time, help us determine whether we should choose a drug that targets the estrogen receptor or targets the HER2 receptor. The second type of test we do for precision medicine in breast cancer is Oncotype DX or MammaPrint, where in some early stage ER-positive breast cancers, we might do this type of genomic test to help us understand how aggressive the tumor is and whether or not chemotherapy might be beneficial. And then finally, next generation sequencing, which is a newer test, something that's still being developed to help us identify what drugs we might be able to use. And importantly, one message I'd like to get across is next generation sequencing, these types of tests, are tests that are being developed primarily right now in the metastatic setting. And so for the remainder of this introductory talk, I'm going to focus on metastatic breast cancer and how we think about using these next generation sequencing tests or genomic tests to inform our decision making in metastatic breast cancer. Now, the goal of using any one of these sequencing tests in metastatic breast cancer is, as I said, to find vulnerabilities in the tumor and then use that information to choose drugs that either target or exploit these vulnerabilities. And that's what we mean by precision medicine using a genomic test. So how does it work? So in practice, when someone gets diagnosed with cancer or with metastatic breast cancer, in addition to the typical radiology and pathology and receptor tests they get, the idea is to take a portion of that tumor sample and to send it to either a local lab in an academic center, in a hospital, or a company that does this type of work, and they look at the tumor, they identify regions of the DNA that are altered, and come up with a report that identifies in that individual's tumor what are the particular mutations, particular genes that are dysfunctional that might have implications for therapy. Now, that's the idea, and these types of tests have been developed at a lot of hospitals and cancer centers around the world, and there are a number of companies that also do this type of testing. This is available to people who get their care at some of these academic centers who do this type of testing, or for patients who may send their tumor to one of these companies. I want to emphasize that this type of genomic testing and this type of precision medicine is still a very new and developing field. And what I mean by that is we are still learning how to use this type of test. There isn't yet consensus even amongst experts who develop and study these tests exactly how to interpret what results come out of them. Many physicians, there isn't consensus among many physicians either about how to interpret and how to use these tests. And many physicians, to be frank, haven't been trained on how to use these tests because they are frankly so new. And finally, I'll say that we're still building up the evidence to help us interpret these tests. And so here the technology has advanced so rapidly that we can do these types of tests on tumors and understand many genes that are dysregulated, but we're still learning how to interpret them, what to do with that information, and what types of drugs or clinical trials we can use. So what can we do right now in 2017 with genomic tests in metastatic breast cancer? The first choice one would like to make with a genomic test for metastatic breast cancer is to help us choose an FDA-approved therapy. I'll say that right now in metastatic breast cancer, there are no FDA-approved therapies that are indicated based on the results of a genomic test. And the main reason for that, in contrast to something like lung cancer or melanoma, is that we already have our classification scheme, and we've had it for many years, and that's using the estrogen receptor, ER, and HER2 to help us classify a breast cancer into a subgroup and choose a drug based on that. And so that's really the test that we use to classify breast cancer, and that's how we choose our initial therapies. And genomic testing has not yet added any additional information to choose an FDA-approved therapy beyond that old and existing testing. So the mainstay right now in genomic testing, the things that we can use this information for, are helping us to enroll patients in clinical trials. And so there are a number of emerging genomically driven clinical trials where we can use this type of information to choose a clinical trial that might be most appropriate for us. There are specific genes that, when mutated, might suggest that a clinical trial might be important. And so examples of this include mutations in the estrogen receptor, or ESR1, mutations in ERB2 or HER2. There are drugs now associated with those mutations. Mutations in BRCA1 or BRCA2 that are not inherited but are present only in the tumor, or a gene called AKT1, or various patterns of mutation that might suggest an immunotherapy might be useful for someone. None of these that I listed here are FDA-approved indications for those drugs, but indications that a particular clinical trial might be a good match for someone with these particular mutations. There are also a couple of new models for clinical trials based on genomic testing. One's called a basket trial, where folks with a particular mutation in their tumor may enroll in a trial that targets that mutation regardless of what tumor type they have. Or umbrella trials, where anyone with breast cancer can join a big trial and based on what their mutation profile looks like can be in a different arm of the trial. And finally, a registry, something like the TAPER trial that's run by ASCO, which allows people to use a therapy and then record what happens to try and make connections between their response to therapy and the mutations they had in their tumor. The third possibility from genomic testing is to use a drug that is approved in another therapy off-label. And I'll say that there are some rare anecdotes of patients who have used these types of off-label therapies based on a genomic result and have had great responses. But I'll say that also that this is the exception, and these stories are rare. And most of us doing research in this area recommend right now to use this information to enroll in clinical trials for a couple of reasons. One, because the safety is monitored, and also because then we can learn from the results of that use. And the last thing I want to talk about is which samples to profile. One thing that we've learned from work done in my lab and many other labs around the country is that breast cancer evolves. It evolves when it goes from primary breast cancer to metastatic breast cancer, and it evolves as patients get more and more therapy and those tumors become resistant. And so most of the time when we do genomic testing, we go to the original tumor that was biopsied and we try to identify alterations in that original biopsy that might help us enroll in clinical trials. But that doesn't take into account all of the evolution that's happened in the tumor over time, especially the resistance mutations. And so more recently, a paradigm that's emerging is to either repeat a biopsy in the metastatic setting to see what changes exist, and also the advent of liquid biopsies. Liquid biopsies are basically doing a blood test which looks for DNA that's circulating in the blood that's shed from the tumor, which may allow us to actually do the same type of genomic profiling without doing a repeat biopsy. And in my view, it's these two areas, either doing repeat metastatic biopsies or through liquid biopsies, where we're going to see the most impact in the coming years, because we'll be able to identify these resistance mutations as well as new targets that we can use combination therapies to help overcome resistance in the metastatic setting. So the last thing I'll say to close is we clearly have a lot of potential from this genomic testing, but as you can see, we're not quite there yet. There's a lot more that we need to learn before we can take this information that we can get from everyone's tumor and use it in the way that we want to be able to pick the right drug for the right patient at the right time. And the way we're going to get there is through research, and it's through our ability to study samples from lots of patients and connect that information to their medical records and really start to make these connections between which mutations and which tumors respond to which drugs, so that we can actually come up with rules that the next person who gets a genomic test can look up and decide what they want to do. And there are a number of really important initiatives right now that are collecting tumors, sequencing them, sharing the data. We're doing something like this at Dana-Farber, where we've biopsied now over 200 patients with metastatic breast cancer, and we've done comprehensive profiling on all of them, and we're sharing this data. There's a project called Project Genie that's run by the AACR, where 7 big academic institutions are pooling all of their genomic data with clinical data, and that's available for people to share. There's Cancer Link that's run by ASCO, which shares the medical records and genomic testing from over 1 million people right now. And so there are these efforts that are starting to gather this information, and this data is starting to be shared, and we're going to learn a lot from them. And I'll close with one other effort that I want to make sure everyone knows about, which is our effort in metastatic breast cancer called the Metastatic Breast Cancer Project. This is a project where patients from around the country with metastatic breast cancer can go to our website, mbcproject.org, and say, count me in, and agree to share their information and their tumor tissue and their saliva, which will help us build this database, which will be shared with all researchers. And it's through this sharing that I think we're going to be able to make rapid advances so that cancer precision medicine can become a reality. Thanks very much.
Thank you. I'm sure, yeah, it's fine to clap. I think it's a lot of information and a lot of new terms and things to think about. So we have the number to text in, so remember, you can start texting whenever you want. Janine will be starting to sort through them. But at Living Beyond Breast Cancer, what we like to do when we talk about things like this is to really talk to some of the women who have experienced this, because we think it's great to learn from their experience, and sometimes it's a little bit more understandable and more translatable. So we're going to bring in Kristin Kilmer, all the way from South Dakota. I think she's going to come up on the screen so you can see her. Can you see her? No? Okay, well, she's coming. I can see her. We actually just spent some time with Kristin. She was in Philadelphia last weekend when we did our conference for women living with metastatic breast cancer. And she has herself had genomic testing and has made some treatment choices based on what she learned. So I'm going to give her a chance to tell her story, and then we'll talk about it. Go ahead.
Hi, this is Kristin. I was diagnosed stage 2B in 2011, and that was with ER/PR positive, HER2 negative cancer. Did kind of the usual treatments, the chemo, radiation, and was on hormone therapy with tamoxifen when I developed my metastatic recurrence in 2015. The oncologist that I was seeing at the time had mentioned the possibility of doing a genomics test to me, but kind of discussed the limitations of it, that you don't always find actionable targets, that insurance doesn't like to cover it oftentimes. But I knew that it could provide options, maybe potential options for clinical trials for myself. So I decided to proceed with it. When we got the results back, he kind of looked at the mutation list and then really focused on the one that matched the treatment that he had recommended, and said that this was evidence that I should proceed with just that treatment. And so at that time, he hadn't mentioned the rest of the tests. So at that time, I asked for a referral, a second opinion, just to talk to another doctor. So I went to Avera, which is about 6 hours away from my home in Spearfish, South Dakota. So I went to Sioux Falls. And when I met with them, they told me that I had great mutations. I actually had 8 actionable targets and then 7 of unknown significance on my report. And so they had talked about lots of different options and possibilities to try to keep the cancer under control for as long as possible. To the treatment that my other oncologist had recommended, they added another drug to that. And then they've been monitoring me with PET scans and liquid biopsies every 3 months. My PET scans have been clear since January of 2016. And then my liquid biopsies, I had one treatment change due to a resistance mutation that had shown up in that. And then they're talking about potentially switching treatments again to target the one remaining mutation that shows up in my liquid biopsy.
Well, thank you. Well, first of all, we're so happy you're doing well. That's the best news. So I think her story brings up a lot of issues. I mean, one is based on where she lives, she's traveling nearly 12 hours back and forth to get her treatment. I mean, I think the way she's even describing it, we're all like, what do you mean mutations in your, so sort of a whole new language. So tell us, you know, what, in general, what do oncologists know about this, and what are they recommending, and how common is her experience?
Yeah, I think it's a great question. I think it's a really interesting story, and I imagine not a unique story of getting a genomic test and getting differing opinions about what to do with that genomic information. As I said, we are in the early days of trying to interpret this information, and so it's not unusual, I would say, for an oncologist to look at this type of test and have a different opinion about what it means. The other reason that there are differing opinions is that every patient and every oncologist is going to have a different threshold for what level of evidence they need to convince themselves to go with a particular course of action. And what impacts those decisions are, again, personal preference of the patient, personal preference of the oncologist, and also the situation. You know, are there other standard of care therapies available, or is this a patient who has gotten, you know, all the standard of care therapies, and now there are no other standard options left, and there's a clinical trial is the only option. And then the last thing I would say is it also depends on what's actually available. So we talk about, you know, when I spoke, I said, you know, our ideal use for genomic testing right now in the metastatic setting is to use to use the information to help enroll on a clinical trial. Well, that's easy to say as long as there's a clinical trial to enroll in.
Right.
And you know, right now, less than 5% of adults in the U.S. enroll on clinical trials, and a large part of that is because clinical trials are not available to patients with metastatic breast cancer very easily. So it's complicated.
Yeah.
And so, you know, this is one of the routes I think that many patients take, which is to come up with a strategy with their oncologist, an oncologist who feels comfortable with genomic testing and interpreting the tests on their own, to come up with a treatment regimen.
So for the people watching and listening, how likely is it if they go to their oncologist tomorrow and said, you know, I just watched this program on genomic testing, how come you've never told me about this? I mean, how likely is it that most oncologists are talking about this when you think about community cancer centers, all the different places people are getting care?
Yeah, I think I don't know the numbers, but I would say it's an emerging technology. And again, this is not something that genomic testing in breast cancer is not something that's FDA approved, and it doesn't help us choose FDA approved drugs. And so, you know, as physicians, we're trained to go by the evidence and go by guidelines. And genomic testing at present does not fit into evidence-based guidelines. And so it's something, you know, I spent years working on this. I developed these tests, and I am a full believer in the power of these types of tests, but we are still working hard to develop the evidence and develop the information that will allow these tests to actually become part of standard care. So it wouldn't be surprising if many oncologists say, it's really interesting, it's really exciting, but it's not quite ready for prime time, it's not reimbursed by insurance companies, and even if we find something, we don't have clinical trials available to us right now to be able to do something about it.
And Kristen, are you doing this within a clinical trial?
I am doing it within a research study. I don't know if they consider it a clinical trial.
Okay. And are you having to pay out of pocket for anything?
I do not have to pay out of pocket for anything. We are working with companies on patient assistance, applications on that. And then what isn't being covered by those is also being covered by my cancer center.
Okay, but those are important questions for patients to ask, right? Because if they're getting a drug that isn't approved, that's usually not paid for, right?
That's right. So it's tricky. So if outside of a clinical trial, if a drug is not FDA approved for that indication in breast cancer, there's a chance that the insurance company won't pay for it. And there's countless stories like that of a physician suggesting a particular drug that's off-label and insurance companies not paying for that. And so this is an important dialogue to have, especially oftentimes if there's a compelling rationale, if there's evidence, if there's prior study that's been published to suggest that this is the right drug, a lot of times insurance companies will reimburse those drugs, but it often takes a lot of work to show that there is evidence to support it.
Right, so there's a lot we have to learn about that, right? Well, thank you, Kristen. Do you have anything else you want to add?
I don't think so. I mean, I think that pretty much covers everything. But yeah, insurance doesn't cover a lot of things. Insurance hasn't paid for the majority of my drugs since September, actually. So that's all been through patient assistance.
Okay. Well, you'll be staying with us in case other questions come up. So, but Janine is going to share a story of another woman who has had genomic testing, wasn't able to be with us this evening, but she has allowed us to share her story.
Thank you. So I'm very pleased to share this story from Maryanne. Maryanne, if you're watching, we're sorry that you couldn't be with us, but we're very pleased to share your story and hope we do it justice. Maryanne was diagnosed with hormone receptor positive early stage breast cancer 14 years ago, and she has had metastatic disease for 4 years with 11 progressions. Maryanne had her first genomic test in December 2014 using tissue from her liver mets, and the resulting report gave her a list of possible treatments and clinical trials. These included Ibrance, which was FDA approved a couple of months after she had her genomic test. So she started that treatment and took it for 10 months until she had a progression. At that point, her doctor did a liquid blood biopsy test, which found a mutation that matched a clinical trial Maryanne wanted to join, but unfortunately the trial had closed, much as we were just discussing. Her doctor then did another tissue biopsy and sent it to a different company. That genomic test showed mutations that made Maryanne a good candidate for Afinitor and Aromasin, but that treatment caused a lot of severe side effects, and she wasn't able to continue to take it. Maryanne then had another liver biopsy that went back to the first testing company, and those results showed completely different mutations. It showed that she had a HER2 amplified disease, so it was HER2 positive, but not enough to be eligible to take drugs like Herceptin. Her doctor offered several new clinical trials, but unfortunately at this point, Maryanne had had so many treatments, she was not eligible for those trials. Then last December, Maryanne developed lung mets, and she had yet another tissue biopsy and a liquid biopsy, which is now being analyzed at her home institution rather than at one of the companies. So summing up her experience, Maryanne says, genomic testing has had its ups and downs for me. I had hoped the tests would find mutations that would find a targeted treatment that would work for a long, long time, and then I'd move on to the next one, and the next one, and the next. But I would still do it again. I have a 27-year-old daughter, and I'm determined to get answers. Why am I getting such mixed responses? Why are there people who have been on the same treatments for years, but I'm not? Despite everything, I still feel like it's all been worth it, even though it hasn't been a magic bullet for me.
Thank you, Janine. And we're all thinking about Maryanne, and I think that her experience, I mean, isn't that much different than a lot of women going through metastatic breast cancer without genomic testing, that they're moving from treatment to treatment and not knowing why. But Maryanne went to those extra lengths by having both tissue biopsies and liquid biopsies. So how common is it that women might go through these genomic tests but really not have anything, as we call, actionable? Or
Yeah, I think in breast cancer, this story is typical in 2017, which is, as I said, we have amazing technology that allows us to do repeat biopsies and analyze the DNA of these repeat biopsies, and now do liquid biopsies and look for circulating DNA that's shed from the tumor and analyze the mutations in the liquid biopsies. But what hasn't caught up is our ability to do something about this. And so, the number of drugs that we have that we understand are connected to particular results from a genomic test are limited. Our ability to do clinical trials, and anyone who wants to enroll in a clinical trial, is also limited because of eligibility criteria restrictions and accessibility restrictions. And so this is a perfect case of someone who's willing to kind of undergo testing, but that the science has not really caught up yet, unfortunately. And the only other thing I'd add is that information that she generated by having these repeat biopsies and liquid biopsies, in the ideal world, hopefully that goes to research, and so that we can learn from not just her, but from every patient who has this type of information, and start to recognize patterns and start to recognize drugs that should work, and answer exactly the question she raised, which is, why did this drug work well in one person but not in me? And if we can, compare the two tumors and compare all of the other features of these two patients across many thousands of patients, well, maybe we can start to understand why there are subtle differences between people and their response to therapies. And that will really allow us to maximize the potential of these tests.
Mm-hmm. So how do patients know who's doing these tests? I mean, what are they, companies, universities? Are there questions patients should be asking about that?
I think if a patient talks to their doctor, and I think if they decide that genomic testing is something they want to do, there are a few different options. Many academic centers now are doing this type of test. Many cancer centers are doing this type of test. At a lot of cancer centers, this type of test is provided. So for example, at Dana-Farber, where I work, every patient gets a genomic test, a panel test, as part of their care, paid for by philanthropic contributions to the Institute. Other options include companies, and there are now a number of companies that do this type of testing. And how to get that type of testing is tricky because reimbursement comes into play. As right now, these tests are not usually FDA approved or reimbursed by insurance. Sorry, not FDA approved, but they're not usually reimbursed by insurance. And so oftentimes there is a question of how they're going to get paid for. And so it's important, I think, one, if the decision is to do genomic testing, to think about where the testing is going to be done, whether at one's home institution, at a nearby cancer center, or at a company, and then making sure how, there's a plan for how this is going to get paid for.
Okay, so important for people to think about. And then Maryanne also had the experience of her cancer changing over time. So can genomic tests help explain that?
For sure. That is one of the most interesting and important things we're learning about metastatic breast cancer. I would say, we recently presented at the San Antonio Breast Cancer Symposium in December our studies of ER-positive metastatic breast cancer, finding that these tumors really do evolve in the metastatic setting. They develop mechanisms of resistance and other genomic changes that weren't obvious in the original diagnosis. Even simple things like changing of receptors, as we heard about here. A tumor can start out ER-positive and then become ER-negative, or or become HER2 positive or switch to triple negative. And one of the benefits of this repeat testing, not just repeat genomic testing, but just repeat tumor testing over time, is to understand how tumors evolve and making sure that the therapies we choose match what the tumor looks like now and not what it looked like 3 years ago or 5 years ago.
Right. So I know we're getting a lot of questions,
Okay.
so I'm going to let Janine start.
So I'll start with our first question, which is, do you need to go through a series of standard treatments before having genomic testing? Does it matter, or can you go from the start? Can you get it done on your own if your physician doesn't support it?
Yeah, so all of those are great questions. I would say there are no rules right now, again, because we're trying to create the rules. We're still studying this and learning. Standard therapies are standard for a reason, right? They've gone through rigorous testing, clinical trials, they've been approved, we know they work well in many patients. And so genomic testing can be informative in those situations, certainly. But there are no rules about whether you do genomic testing now or do you do genomic testing after standard therapies. A lot of times genomic testing is part of a clinical trial, and so oftentimes the decision to do genomic testing may be coupled with the decision to try and enroll on a clinical trial. For example, some of the trials I was talking about, like the MATCH trial, a basket trial run by the National Cancer Institute, genomic testing is part of the entry criteria for that trial. So when a decision is made to go on one of those trials, you might get genomic testing as part of the decision to see which drug in the trial you get. The last part of the question was, what if you want to undergo genomic testing on your own and your doctor doesn't support that? I think that's a really tricky question. I think these conversations are always really good for patients to have with their doctors and understand. It's important for the doctors to understand, why their patients want a genomic test, and they may not see it that way. And I think it's important for the patients to understand why the doctor is not recommending to get a genomic test. And that dialogue is really important. It's certainly possible to get a genomic test if you want one, and that can be discussed with the pathology department and a company that does the testing. But again, it's important to think about after that test comes back, one, how's it going to be paid for? And also, what are you going to do with the results? If the physician has to be involved at some point in making decisions, or some physician has to be involved at some point in making decisions. And so this, I think, is best done as a joint decision with someone.
And someone has to read the results.
That's
also,
right.
Because I think we've had a lot of questions about who reads this, who interprets it, So you want to be with someone who can help you sort this through.
Yeah, and that's another really tricky question, something that I've been involved in for a long time, which is how do we interpret these results? And you can get genomic testing from multiple companies and multiple academic centers and look at the reports on the same tumor tissue, and the interpretations might differ. Mm-hmm. And that's not because someone's bad and someone's good, it's because this is still subjective to some degree. And so getting a genomic test involves getting an interpretation, and one could get a second opinion on the interpretation, as in the story we heard earlier. But again, this is a developing field where even experts can disagree about the interpretation of this.
Okay, go ahead.
So our next question is about heterogeneous tumors, and we have a couple questions about if you could explain what that is, why that's a concern in genomic testing.
Sure. So the idea of tumor heterogeneity means that not every part of a tumor or not every metastasis in someone's body looks the same. And so that even though everything started from one tumor cell, as they spread and grow, they might evolve in different ways. And so that in the patient with metastatic breast cancer, they may have some parts of their tumor that look a particular way and other parts of their tumor that look a different way. And when we do a biopsy, we are, by definition, putting a needle into one portion of the tumor and looking at that one portion of the tumor. And we're assuming when we do any kind of test, ER, PR, HER2, or a genomic test, that all of the tumor cells look like that one tumor cell that we biopsied. And we think that that's probably not true. We think that it's more complicated than that. And so the issue, yet another layer of complexity here, is that if we make a decision based on what we find from a particular tumor biopsy, maybe that won't apply to all of the tumor cells. And maybe that will matter, but maybe it won't. And that's another thing that we don't quite know yet. One of the ways that this is being addressed is with liquid biopsies, right? So if liquid biopsies, if the idea is that they're getting DNA that's shed from every little bit of tumor in the body, then maybe they will incorporate all of the differences in the tumor cells in the body, and we will be able to get a whole picture. That's something that's being tested. We think that might be true, but we don't know yet.
So there's actually a lot of questions about liquid biopsies in general and why they seem to be controversial. What are the differences between them?
Mm-hmm. So I'll explain liquid biopsies a little bit more. It was found some years ago that tumor cells shed pieces of their DNA into the blood, and that circulates. And with the right technology, if you take a blood sample from someone with metastatic breast cancer, you can actually identify that DNA that comes from the tumor in the blood, alongside normal DNA that comes from normal cells. And when analyzed appropriately, you can identify the same mutations in the blood that you would be able to identify were you to biopsy that tumor. We've done studies where we've done biopsies from someone with metastatic breast cancer and a liquid biopsy at the same time and compared them, and in many cases they look remarkably similar. And so I think we're excited that liquid biopsies may be a way to look at the tumor without having to do repeat biopsies over and over again. The reason they're controversial is because this is still, again, like many things I've said today, it's still very early days. Liquid biopsies are a new technology. There are several companies that have liquid biopsies. There are several academic labs that have liquid biopsies. And the studies have not yet been done, both to adequately compare them to tumor biopsies and also to think about this idea whether if you make a decision based on what's present in the liquid biopsy, will that have benefit for people? And there are some promising results. There's been a lot of studies that have been published lately or presented at meetings that suggest that this might be the wave of the future. And many of us, including myself, are very excited about liquid biopsies. But it's controversial because it's early.
Well, another sort of follow-up to that question is from someone who's asking if they have a metastasis in a place that's hard to reach, could they use a liquid biopsy instead of a tissue biopsy to get some guidance for treatment?
Yeah, I think that's certainly the hope. And liquid biopsies don't tell you everything. Liquid biopsies right now, you can do panel testing. You can do this genomic testing off of liquid biopsies, but you can't test if the tumor is still ER positive, and you can't test if the tumor is HER2 positive. That requires tissue right now. And so, so in the absence of anything else, if someone is looking to enroll in a clinical trial and they need a genomic test to figure out if they can enroll in that clinical trial, in some cases, a clinical trial will allow a liquid biopsy to allow them to enter that clinical trial. So it's certainly a possibility.
So I would imagine for some people watching who are living with metastatic breast cancer that this could be frustrating for them, and it feels like you're sort of figuring it out along the way. So one question we have is, where is all this data going?
Yeah.
And how is it shared?
Yeah, that's a great question. And I talked about this a little bit in the beginning, but this has become one of the fundamental questions of this field. I think everyone has started to realize that we can't solve this problem if we silo all the data at every individual institution or every individual company and just look at it ourselves. And that we're only going to learn from the power of big data, where everyone takes all of this information and we pool it together and we share. This is starting to be done now in multiple kind of intermediate-sized groups. Like I mentioned, Project Genie, which is 7 big academic institutions that have pooled their data, and ASCO's Cancer Link. The National Cancer Institute has something called the Genomic Data Commons, where they're encouraging everyone to deposit their genomic data. And if you have federal funding to generate your genomic data, you have to deposit it in there. So we're starting to make progress in sharing. One of the things that we decided to do in the Metastatic Breast Cancer Project is go directly to patients and say, if you want to help accelerate this type of work, we're asking you to share, and we will make this data publicly available. So there are a number of efforts, and my hope is, and what Vice President Biden said in his moonshot, is take all of these now groups that are aggregating data and aggregate all of that. I think it's coming, and I think we're going to learn a lot from that.
Okay.
So we have another question. In a lot of ways, genomic testing doesn't sort of look at cancer the way we typically do it in terms of subtypes, but I'm getting a lot of questions about whether there are particular subtypes like triple negative where genomic testing would have more value than others.
It's a good question. I think one of the frustrating things about triple negative breast cancer is that we talk about it by what it's not. It's not ER positive breast cancer, and it's not HER2 positive breast cancer, and so we call it triple negative breast cancer. One of the hopes is that genomic testing will help identify something in those tumors that is the driver, that is the vulnerability that we can target with a drug on a clinical trial that will help patients with triple negative breast cancer. There's a lot of work that's being done here, but as of yet, we have not found a single gene or a single mutation in triple negative breast cancer that's the driver. And it is probably because triple negative breast cancer is really a collection of multiple subtypes. It's not just one thing. And genomic research is looking to take triple negative breast cancer and actually subclassify it into the particular categories where we won't call them triple negative breast cancer anymore. We'll have different names for each of those categories, and then we can develop treatments for each subgroup. That's something that is, I'd say, promising, something that lots of people are working on, but again, something that we're still not there yet.
So I think at our conference last weekend, I don't know if this was Dr. Yee or someone else, but mentioned that breast cancer could be moving to become like an orphan disease, where it's very, very, very specific. And what would that mean for patients and get new drugs being found and progress?
Yeah, so I think there's evidence of that already. Evidence where there are specific mutations that allow people to enroll in clinical trials where their tumor has a particular fingerprint. And that fingerprint, that genomic fingerprint, makes their tumor behave differently than someone else with the same subtype. And in those patients, in patient 1, you might choose one drug. In patient 2, you may choose another drug. The issue, and so I agree that that may be where we're moving. The issue is that the drugs that we're choosing for these different fingerprints are all still in development, right? They're in clinical trials. And so we do not yet have, I'm very hopeful that at some point soon we will have a whole host of FDA-approved drugs that we can pick and choose for every person based on their genomic fingerprint. We have to complete these clinical trials before we get there.
Right, so it sounds like we're talking a lot about clinical trials, which is so important.
So another question that we have is that if a mutation is found and treated, is the goal to eliminate the mutation from the cancer?
The mutation's a marker. The mutation is something that we see in the tumor that indicates a feature of the tumor. And so the goal is to target the mutation in the tumor because we believe that that tumor requires that gene and that mutation to survive. And so, an example that's well known in breast cancer is HER2, right? HER2 is a protein that's expressed on the surface of breast cancer. When we know it's there, we pick a drug that targets HER2, and those tumor cells die. And the goal is, can we find more things like HER2 in other patients' breast cancer?
So Kristen had mentioned that, I think you had said, Kristen, that you have not paid for your genomic test thus far. Is that right?
That is correct. Either the company has provided it at no cost or Avera has covered it, my medical center.
Thank you. So in general, how are people paying for these tests? How expensive are these tests, and how are people paying for them right now?
Yeah, so that's a really good question, and one that I don't know the answer to in terms of what percentages of people are paying out of pocket versus when insurance is covering it versus when a cancer center is paying for these tests. I know that many cancer centers like ours, the tests that are done in-house are provided to patients, and it sounds like that's a similar situation here. I also know that there are other folks who get tests from companies where some insurances may pay for it. I don't know, which ones or which companies or what percentage of people that is. And I know there are other people that pay out of pocket. It's a really tough decision because these tests are expensive to pay out of pocket. And as I said, they're not part of guideline-based care right now. And so people are really paying out of pocket for something that is not yet evidence-based. And so it differs based on the situation, and it differs based on where you're getting your care.
So I want to make sure we give everyone some practical information, because I think that they might be listening to this program and say, it sounds like this is early, but we know Kristin's doing it, we know Maryanne did it. So can you kind of just give what are the pros and cons? What should women be thinking about when they weigh this decision, even to go have the conversation with their doctor, about whether they want to start down this road? Because it does sound like it's a road. It's not necessarily one test.
Yeah, I think that's it's a great question. I think about genomic testing in metastatic breast cancer as something that's part of research right now. I think it's, not everyone may agree with me, but this is something that we are still trying to develop and understand. And that's why I'm talking about clinical trials so much, because when linked to clinical trials, we can actually study whether this type of genetic testing, genomic testing, is helping people. Because we do the test, we use that to enroll someone on a trial, we see if they respond well to the drug on the trial, and then we know that this, or we're starting to get a better idea then, that this test result was linked to a good response to a particular drug. And that may be on a clinical trial, it may be through a registry like ASCO's TAPER study, but it's in some way studied. So I think people should think about this type of testing, certainly when it's linked to this type of research. I think it becomes more complicated when people hope that the results of the test will tell them, a particular drug that they should use, and it's going to have a great result, because those stories at present are still few and far between. We're still studying this. There's not a huge host of drugs that we can just look at a genomic test and then pick a drug off the shelf and say that will work. That's certainly our goal in the long run. But in 2017, we're not quite there yet. So practical advice, I think if folks are at a center that does this type of testing, then that center will be experienced with that information and how it's going to be used. If not, I would strongly recommend a conversation with their physician to say, I'm interested in genomic testing. I want to understand what are the different possible outcomes that might happen from genomic testing and how it's going to be paid for, if it's going to be paid for. And I think those conversations up front will help set expectations for what's going to happen when the test is actually done. Until the point where we actually have a huge number of options to be able to use from genomic testing, I think those conversations are probably important up front.
And I know we're talking really right now about women with metastatic breast cancer, but what if you are early stage? And I know we're not going to get too into that, but do you want to just give a little preview for what might be available for women with early stage breast cancer? Can they be followed by genomic testing?
Sure. So there are a few different things. One is that there is part of guideline-based care is to do a version of genomic testing like Oncotype DX or MammaPrint on women with early stage ER-positive breast cancer. And that's part of standard of care. It helps decide risk of recurrence and risk of chemotherapy. So we're not talking about that. Then there's this idea of what we're doing in the metastatic setting. Is there a role for doing this type of genomic testing to figure out, are there specific targeted therapies or clinical trials that one might do in the early stage setting? For the most part, at present, no, right? This type of genomic testing to pick a drug is really right now being studied in the metastatic setting. The third possibility is to do this type of liquid biopsy in early stage breast cancer to monitor for recurrence of disease. The idea being that in early stage breast cancer, after surgery, there's no more evidence of cancer in the body, but if cancer comes back, maybe it will shed a little bit of DNA into the blood that you can detect with a blood test instead of having scans, all the time. That is a really exciting, really interesting idea that many people are looking at and many people are trying to figure out if it will help. There are studies that are looking at this right now. It's not standard, so you can't go and buy a blood test to see if you've had recurrent disease right now, but certainly one that I think many of us are excited about.
Right, so that might be something we want to cover another time of
sure,
what
yeah,
can you do in the early stage. Do you have a question, Janine?
Yes, so we've talked a lot about the limitations of these tests now, but where do you see us in 10 years, 20 years from now with using genomic testing?
It's a great question. Like I said, I'm a true believer that we will be able to use molecular and genetic testing to subclassify everyone's tumor into this small little category and pick and choose the right combination therapies for them. And those combinations may include regular chemotherapy, targeted therapies, hormonal therapies, immunotherapies, but the right combination of drugs based on every individual's genomic and molecular fingerprint in their tumor. And then monitor this, as we've heard today, monitor this over time, figure out which drugs are working, which aren't working, modifying the regimen, and using that approach to ultimately cure every individual's metastatic breast cancer. That's, I think, all of our goal. That's where we'd like to be. 10 or 20 years is a long time, and I'm hopeful that we can get there, and many of us are working on exactly that.
So Kristen, before we let you go, do you want to just, since you have said, I'm going to step out there and do genomic testing, do you just want to say how did you make that decision, and how do you feel about sort of being part of this, knowing we're not quite sure how it's going to work?
I think the main decision maker for me was I'm mother to a 10-year-old daughter, and I really honestly felt that even if it didn't end up ultimately benefiting me, that it did add to the science and would help, hopefully down the road for her generation, make this at the very least a controllable disease, if not a curable disease. So that was really my driving factor, and that's what spurred me to make the decision to say, sure, test it on me, try it on me.
Yeah, well, good for you, and I guess good for a lot of the other people that are trying this. Well, I can't believe it, but we've spent this hour, and I know we probably have a lot more questions, so we will try to answer them. Remember, this program will be available immediately, so you can watch it again. Nick does have slides that we didn't let him show, but we will make them available so that you can really look at this and better understand it. We really appreciate you taking this very complicated subject and trying to break it down so everyone can start to understand it and start having conversations with their doctor and making decisions. Again, I want to thank Genentech, Genomic Health, and Merck for their support. I want to thank all of you for participating. I know that you'll be getting an evaluation form, so we encourage you to fill that out. And stay in touch with Living Beyond Breast Cancer. We continue to do programs all year long, and we want to hear from you. So thank you, everyone.
Thank you.
Thank you.
Thank you, Kristen.